All right. Can you guys just start off with maybe like a 30-second summary of what you're currently doing with the Perioscope?
Go
Like,
ahead,
can you?
Peggy.
Thanks.
Sure. I take my perioscopy business on the road. I provide perioscopy therapy for any general dentist that asks me to come into their office to treat their patients.
hmm Do you work regular hygiene too, Peggy, or just
I do. I
you
do.
do?
Unfortunately, I'm not busy enough with my business yet
hmm
that I can give up my regular business. I do it for both of the dentists that I do regular hygiene services for in addition,
Yeah.
but then there are three dentists that I strictly do perioscopy business for them.
Okay. Francis?
I do something kind of similar to Peggy, only I'm only in one office, but I am independent in that one office. So I don't necessarily, so other people can refer patients to me. I've had other independent hygienists send patients to me for perioscopy, and that's in Colorado, but I actually live in Utah. So in Utah, I work with a periodontist on an as-need basis. So I
hmm
kind of have two different things going.
So with the periodontist, are you an employee or are you still an independent person coming into the office?
Um,
Or is it kind of if like difficult to be independent, I guess?
yes, here in Utah, it's you're not independent. I assume it's similar to Peggy, your contract.
All right, so I'm not allowed to be. I can get paid with a 1099, sort of.
hmm
I am not allowed to. I am not allowed to get paid per service. I have to get paid per hour. If I get paid per service, that is called fee splitting, and that's against the law in Nevada. So I charge by the hour. And some of the dentists pay me with a W-2, some of them, or W-4, whatever that is, and some pay me with a 1099. But I'm not allowed to fee split, so mine has to be paid by the hour.
Gotcha. How did you guys first discover the Perioscope? What was the first time you came across it?
All right, I'm going to go first with that. I worked in a big perio practice here in Las Vegas, and there were three periodontists, and the older dentist actually came back from some type of a convention and said, "We've got to have this." And so Dental View, who used to own Perioscopy Inc., or was the precursor to the technology, came in and trained everybody. But at that point, the machine was not where it is now. It had its flaws. So they didn't sell a lot of machines. The technology would have gone under had not it been for Dr. John Kwan, who purchased the rights to the company in 2007. And he was Perioscopy Inc. But about that time, we had a renewed interest in the perioscope. So we actually, the hygienists in the perio practice I was working, went up and worked with Dr. Kwan for some time, and he had retrofitted his machines to where they are now. And we started working with the scope. All of the perio patients then became scope patients, and the doctors did everything except treat perio disease. They turned it all over to us, and it became very, very successful.
How about you, Francis? How'd you first come across it?
I had read an article in the RDH magazine, and it was written by Judy Carroll, who does periopeak.com. Anyway, I was so intrigued by it that, because we all have our patients that we scale and root plane so diligently like we've been trained in school, but they really don't get any better, and you just can't figure it out. So I actually flew up to Seattle and watched her for a day, and the gentleman that she had come in was actually a guy that flew in to see her specifically from Chicago. And so it was really interesting watching what she does and things like that. But it was so amazing to know this gentleman had been scaled and root planed twice, and she stuck that camera down there, and I was blown away by what all you could see and what we as diligent hygienists leave behind and how she was able to remove it. So I was so intrigued by it, and then probably about a year later, there was another article, and Peggy happened to be in that article, and I called her and flew down to Vegas, watched her, and then that's when I decided to buy my own equipment and flew Peggy up to Colorado, and she trained me, and the rest is history.
Mm-hmm. Do you guys have the new system, or just like the old scope with the modifications?
Yeah, I have two of the old scopes with the modifications.
Mm-hmm.
Mine is the old one with modifications also.
Yeah. All right.
There are two kind of new companies. I don't know how you describe them, but Danville actually bought out John Quan. So John Quan does not sell the machine anymore, and they are trying to. And you had Suzanne Newkirk on a while back, and she's part of that team also. And they're trying to put together a better machine, better equipment, more mobile, things like that, and more geared, I think, towards a hygienist, being able to own our own. And then there's another company, and I can't remember their name, and they are trying to do something very similar. So there's a renewed interest in it, and there are two new companies out there working on it, trying to do it so that we as hygienists can actually have it at our fingertips.
Very nice.
Tryon.
Say again?
It's called Perioscopy.
Mm-hmm. Okay. That second company you're talking about? Right?
Correct.
All right. So can you guys talk a little bit about, I guess you kind of touched on it already, but just the path from discovering the perioscope to what you're doing now, basically maybe some of the difficulties or challenges. Yeah.
There's a few of those. So a few years ago, my boys were out of college, and my car was paid off, and I had money in the bank. And I was doing all of this work for a fraction, just for an hourly wage for the periodontists, and they were making a ton of money off of my services. And so I contacted Dr. Kwan, and I asked him, how do you think this would work if would you help me? And he was very, very helpful. And he and Suzanne were very helpful in helping me procure 2 machines. And I basically printed up business cards and made up my own flyers, and I went out to practically every dental office in town and gave them my literature and tried to sell myself to come into their practice. And that's kind of where I've been going ever since. I will tell you that the challenges have been many for a number of reasons, and what I found most readily was that I needed the help of the hygienists to get into the office, because the gatekeepers of the office are the front desk. Mm-hmm. It doesn't matter if you send the literature to the dentist, it gets opened by the front desk, and if they don't feel the need to show it to the dentist, they don't. Or if I showed up with a box of goodies, and was very good at introducing myself and offering my services to their practice, most of the time the literature ended up in the trash can. So I quickly found out that I needed the help of the hygienists to get in the office. So it really was beneficial if the hygienists in the practice were not being compensated on a commission basis for scaling and root planning, because if they were being compensated that way, what I was offering was going to take away from their paycheck. So I had a good working relationship with a number of the dentists. The other clarification I need to make is that I didn't want to encroach on the practices that were already referring to my former employers. So I had to find a new avenue. So I have found a few, and I have a good working relationship with them. But it has been challenging to say the least. I've had a few dentists say to me, "Why would I want to save teeth?" They would really rather extract the teeth and put an implant in there. That's been something I went into. I had been approached by 2 perio offices, and I went in and I worked just for my costs on patients, and was absolutely blown away. And they were a little bit mortified by how much residual deposits were left behind by their hygienists. But they're more driven by what the insurance they're contracted for. And let's face it, in a perio office, their bread and butter is surgery. So they really don't want perioscopy. So it's been challenging. I'm not gonna lie about that. It's been challenging.
How about you, Frances? What are some of the challenges on your path to where you're at now?
Probably my biggest one was obviously getting patients in. And so for me, it was, the other biggest one was helping the dentist understand what this is and what it does. It's not, that's probably the biggest thing. The hygienists get it. It's so amazing, and they all would want one, but the doctors just aren't quite sure how they're going to get paid for it, bottom line, and how they'll make money off of it and still pay you. So that's probably been the biggest one. But I happen to work with a dentist who has actually seen some good results from it, and how excited the patients are over. If you can get a patient excited to do this and want to save their teeth, then then you're golden. But that's probably the biggest thing. And so I actually, like Peggy, if you can get in with the hygienist who knows. So I had written an article for our state newsletter and had several sent to me and stuff. The periodontist I work with here in Utah is a little bit different, because he said to me, if you can save me from having to do a lot of gum surgery, especially in areas where we don't get good aesthetics, he says, that's what I'd like to have. And so 8, 9, 24, 25, those areas that they need something, yeah, come in, let's do it. And he can go back to doing implants and leave that area up to us. So more of them need to understand this and what it can do, obviously, to their bottom line. So that's probably the biggest thing, is getting the dentist to understand.
I can imagine. Yeah.
The patients totally get it. They're like, come on, let's do this. But getting the dentist and the hygienist to let you into their practice is another story.
Have you guys treated a lot of patients that either you did a blind SRP and then did it with a perioscope later, or just patients that have had SRP in the past and you've done it with a perioscope? Have you seen a lot of those patients, and what's the difference, and so on?
I haven't scoped a lot of my own SRPs. I haven't scoped a lot of my own.
Have you had patients, Peggy, though, that said that they had a deep cleaning before? And
almost every one of them.
Yeah.
Yes, they've all had it before. The other thing is, I wish I had a nickel for every time somebody said to me, I had, they use the term filleted quite frequently. They've had perio surgery and they'll never do it again. So the thought of having non-surgical periodontal therapy with really predictable, fantastic results easy, is a no-brainer for the patient. The patients are not the hard sell; it's the doctor.
Mm-hmm.
So I haven't seen my own patients because
and because I'm newer at it than Peggy. Peggy's much more experienced than me. I have done some of my own patients, and I have to tell you, it was pretty humbling to all of a sudden see. And I won't say what a crappy job I do, but what an incomplete job I do because I can't see it. I can feel that it's smooth, but I can't see that what I'm leaving behind.
Right.
And so it was extremely humbling to me to do some of my own patients, and yeah.
Do you guys think the SRP with a perioscope should be the standard of care?
Absolutely.
Yeah.
So I was talking to you before we started. We need to talk about, just get one thing clear. There's basically two tracks of of bone loss. One is the true blue refractory perio patient that their body cannot tolerate the bacteria that causes the devastating bone loss. The other periodontal patient with the bone loss is due to inadequate debridement of the root surface. So there are two different two different types of patients that you're working with. The perioscope obviously is going to be better for the second person that just has the traditional traditional residual calculus left on the root surfaces. And my goal would be to make it available for every single dental office. If you cannot, the studies show that you can only get, 50 or 60% of a 5mm pocket, why would you want to go in there and clean that off? Because if you don't, you're going to get bone loss, and then you're creating an environment that the patient can't keep clean. And then you get to the point where it's always going to be a 5mm pocket because they just cannot keep it clean enough. So I do think this is the new gold standard for non-surgical periodontal therapy.
Mm-hmm. Do you agree, Francis? I'm sure you do.
Oh, I do totally. I do totally. Just as a hygienist, to be able to see down in there is so amazing, and you just can do such a better job. The other thing is and there are many different ways to do this also. I use a piezo. I think Peggy uses an ultrasonic. Anna Patterson uses hand instruments. So there's so many different ways to do it, just like there's so many different tools out there to use. But I've yet to have a patient, after I have perioscoped them with my piezo, complain about pain or swelling or anything like that. It's very comfortable for a patient, as opposed to hand scaling instruments for scaling and root planing. And I know, Mark, you use ultrasonics frequently also.
Yeah,
so but to take a piezo down that deep in a pocket and not be able to see what you're doing, pretty scary. But if you can see what you're doing and where you're going, and I also do use diamond tip ones at the very end. And no way would I take a diamond tip in there if I couldn't see.
Mm-hmm. Do you guys hand scale too, or just power scale, basically?
I just power scale.
Yeah, me too.
That's good to hear, because I don't like hand scaling that much.
Can I tell you, anybody that I've done perioscopy therapy on, I very, very seldom after that even pick up a scaler, because they're okay with the fact that we don't use hand scalers anymore, and they accept that. People that don't realize that the power scaler can do it all are a little bit reluctant. They're like, "Aren't you going to scale today?" But otherwise, I'm a power scaler all the way.
Mm-hmm. Let's talk about the fees and billing and how that typically works. How do you guys bill, or not you, or the office, whoever does the actual billing? Do you guys increase the fee? Do you guys have a separate fee for the perioscope? How does that work typically?
Okay, so depends on whether or not I'm working as an independent contractor for the dental office, or whether I'm already working as an employee for the practice. We bill it out as the doctor bills out the 4341 or the 4342, depending on which procedure he's providing services for, and then we charge out $49.99, that unspecified dental periodontal procedure for the periodic aspect of the treatment.
Mm-hmm. Same with you, Francis, or?
No, well, yes and no. At my practice in Colorado, the patient actually pays me the fee. So if there's some scaling and root planing fees that went along with it, then that goes through the doctor. The perioscope actually goes through me. So it's two totally different practices, two totally different billing. Through the periodontist, I'm an independent contractor, and he just pays me a flat fee. He just adds his fee on top of my fee.
For the patients, from the patient perspective, I mean, what's the price difference? Is it about double what blind SRP roughly, or something like that?
So for me, I don't mind quoting my fees. I'm $300 an hour because that includes the cost of the sheath, the fibers, the handle, the explorers or the holders of the fiber. I purchased all my own equipment, the my ultrasonic unit, and everything that goes with it. So in Las Vegas, a typical 4341 is, I'm going to say, in the ballpark of the $250 range. So the patient gets assistance from their insurance company for that 4341, but the $49.99, the $300 an hour is my cost above and beyond, and which then the patient tell them right up front that your insurance is going to cover that. You're responsible for that portion.
Mm-hmm. How about you, Francis? Is the prices similar, like about double, or for the patient, or?
And I'm less. In both Colorado and Utah, our fees are less, but it's pretty much, yeah, that's pretty much exactly what it is. It's about double. And I charge per quad, not per hour, just because of how I'm structured. So.
Right. So
just so you know, Mark,
yeah.
I can scale and I can use my perioscope and do meticulous debridement of the root surface as fast as someone else can do blind scaling and root planing. So it turns out to be pretty much one for one.
Right. And as far as the learning curve, I mean, how long did it take you to get to that point, Peggy?
Well, please understand that when I first started, it was the old machine that was not retrofit with an adequate water supply. We didn't have the correct angulation on our but quite frankly, it was the biggest downfall with the original machines was the lack of adequate water in that pocket, flushing that pocket out, debriding the pocket. So I'm not going to lie, it was probably a couple months before I was really good at it, because we didn't originally schedule every single patient with the scope right up front. First we did blind scaling and root planing, and those patients that didn't respond adequately, then we would go back into those pockets. Well, as we got better and better at it, then it became every scaling and root planing in that perio practice then was scheduled for perioscopy, and we found that we didn't have to go back and do scaling and root planing on a 2-year basis anymore, which is kind of how it used to be. You know, we figure that in 2 years the pockets would start to break down, and we would go back in and do scaling and root planing. Once we did it with the perioscope, we didn't have to do that anymore. So you know what? I forgot what the original question was. Oh, the so once you get everything working for you, it's not a real big factor. Plus, I had to train myself.
Right.
So, you know, also when we first learned, you put your instrument, you put the camera down into the pocket, you view the deposits, you pull the camera out, and you go in there and you know, blindly scale. Well, Dr. Kwan made us realize that that was just like the most inefficient way to do it. Now we scale, we use the Explorer, the camera in there with one hand, our ultrasonics with the other hand, and we do it all with one, you know, at one time. So it's not a scale view. We're scaling and viewing at the same time.
And my thought about that, as far as time goes, is like doing it blind. You're like kind of doing it over and over and over in the same spot to make sure that you're, or trying to make sure to get everything. Whereas with a perioscope, it seems like you would have direct vision, so you know that you're done.
That's right.
Right.
So the other thing you need to remember is that just because it's smooth doesn't mean that, number one, you got it off, and just because it's rough doesn't mean that there's calculus there.
Right.
So it's so much more efficient. It would just knock your socks off. So.
How about you, Francis, as far as your learning curve? Like, you know, how long did it take you to get to where you're at now?
Well, I'm still learning.
Okay.
But I've only been doing it for a couple of years. But I have to tell you, Dr. Kwan, if you go and listen, he likes to teach you by playing video games, and I'm not a video game person. So I just started using my left hand to brush my teeth, to comb I mean, just to do lots of mundane tasks that we normally do, just so my brain started to recognize my left hand more. And I will tell you, there is a big learning curve to it, and that's probably one of the other setbacks to it. You've got to want to use this in order to do it. And then when Peggy was training me, there was one point where I thought I was going to kill her. Because she kept saying, "You see it? Go get it! Go get it!" And I couldn't go get it. So there is a learning curve to it, and don't kill your instructor, bottom line. So.
Gotcha.
And I'm still learning. I'm still learning. I'm still going back. There's just, but it's just so rewarding. I'll tell you, one of the other things I learned wasn't just the calculus, it's the biofilm. You know, we talk about biofilm all the time as this nebulous thing out there, but when you stick that camera down in there and you're looking through a bunch of goo and all of a sudden you use your piezo and it clears up, that's the biofilm, and you just don't even realize how much of it is left down there, and just 2 swipes with that ultrasonic is not going to take it out. It's some tough stuff. So not only the calculus, but the biofilm, and just learning about the environment that all this lives in. So anyway, it's a continual process because you're using 2 feet and 2 hands.
Yeah. Well, to me, that seems like it's very valuable, because like the more difficult it is for you to be able to do this, the more you can charge, basically, you know, because it's not something that anybody can just pick up and do, you know.
Right.
So.
You know, I trained in the office here in Las Vegas, and the hygienist had been preparing herself, and one of the hygienists of the 2 in the practice, she made herself useful for just about everything. Boy, she picked it up like a duck to water. She, within a couple hours, had it all figured out, and just it didn't take much time at all. But that's part of the fun of this, is that it's not, it's like a puzzle, and the challenging part is what makes it exciting. I don't know. To me, a routine maintenance appointment can get a little bit, boring, you know, over and over and over. You engage the patient in this process, they see the benefits of it, and it's just flat out fun, much less, you know, in addition to the benefits that the patient gets.
Very nice. Peggy, you already touched on how you market a little bit. Can you guys talk about that, how you get your name out there and how you get patients, basically? Some of the things you guys do or have done in the past?
Well, mine was strictly legwork. I went to the local dental hygiene association. I went to the state association. I flew at my own costs up to the northern portion, the southern component of Nevada, and spoke to at their monthly meeting. I spent a lot of money on my own brochures, and I put it on Facebook. I just did a lot of legwork to get into the offices that I've gotten into. I'm going to say that I need to do revisit that marketing aspect of my business again, but quite frankly, I've been working 5 days a week, and so I need to start taking some days off, not scheduling myself to do it again. So.
How about you, Francis, as far as marketing? What are you doing or have done?
Basically like what Peggy was saying. Every hygienist I meet, I talk to her about what I do, her or him, what I do. When I temp a lot in Salt Lake here just because I don't want to not be able to fly back to Colorado to my practice. So it's education. Every person that you come in contact with, if they hear about it, if they know about it, if they talk about it, I've gone to the schools here, and I'm going to be doing a couple lectures in the schools to educate people. I just think that's probably one of the key things. The more people know about it and actually understand what it is and how you use it and the benefits from it, then people will want it. So
I have an appointment coming up. I teamed with another hygienist who I worked with. She was the temp in our office. I have a meeting coming up to meet with the benefits rep for the Teamsters Union and I'm hoping that I could get on their fee schedule or whatever the terminology is. Forgive me, I don't know the correct terminology yet, but I'm hoping that I can get Teamsters to understand that perioscopy is a fraction of the cost of osseous surgery, full mouth osseous surgery. It will be better for the patient in the long run, and much less money that they have to expend, less time off for the patient, less pain for the patient, better outcomes for the patient. So I'm hoping that if I can start small and get into the Teamsters, that will lead me to possibly being able to get into the culinary union. And so that's where I'm focusing my efforts at this time.
Mm-hmm. Do you guys think what's the better market, you think, with periodontist or general dentist? Or do you see no difference?
General dentist.
General? Yeah.
Why wouldn't you want to keep having worked in the periodontal office many times, one of the biggest things that the general dentist doesn't like is that they have this perception of the periodontist stealing their patients. And the patients used to say to us, well, you fixed me, why can't you just maintain me? So why wouldn't I feel like approaching the general dentist that you can keep this technology in your practice, you can keep the fees in your practice, you can keep the production in your practice, you keep the patients in your practice. So to me, it's a win-win for the general dentist. Periodontists, I'm going to say it again, unless you have a very enlightened periodontist, their bread and butter is osseous surgery.
Mm-hmm. What do you think, Francis? Yeah, general dentist.
I don't know. I'm just enjoying listening to Peggy. She has such a good way of explaining everything.
Yeah.
I agree. I like keeping it in the general practice, and I haven't really gotten a lot of good feedback from the periodontist because, again, like she said, that is their bread and butter. But in the general practice, if it's explained correctly, it just goes hand in hand with everything we already do. Fortunately, the periodontist here in Utah that I work with is one of the enlightened ones and not wants to just do implants or surgery. So, but yeah, keep it in general practice. You can send it to the specialist at some point if you need to, but you know, I mean, Mark, what do you guys do in your office? Don't you keep them mostly in your office till it gets to be at a certain point and then you refer?
Yeah, I would say so. Yeah.
See, my point to that, Mark, is why wouldn't you, as a hygienist, want to take care of that pocket when it's a 5 rather than waiting to refer it out to 7?
Mm-hmm.
Why wouldn't you want, because you can tell the difference between a refractory patient and a residual calc. Do you know what I'm saying?
Right, yeah.
You know the difference.
Mm-hmm.
So the refractory patient, by all means, send them out. Okay, let that, as one of the periodontists in the practice used to say, why are they gonna lose their if they're gonna lose their teeth due to gum disease, let them lose it in our practice rather than the general practice.
Right.
So.
Yeah. No, that makes sense. So as far as like marketing to the general dentist or periodontist, it seems like it's kind of a no risk situation for them if you're
Thank you.
basically charging them a flat fee or however you're doing it, and if you don't have a patient, they're not paying you, right?
Right.
So it seems like it's a no risk for them. I don't know.
It is a no risk for them. I want to just use that point to say something about the learning curve. That's probably why I learned at a faster rate than Francis did, because I had a continual supply of patients.
Okay.
Okay?
Definitely. That's definitely true. And there's different, the other thing is there's different ways, you know, some of the people out there are doing the saliva testing and the whole systemic link, which is extremely important. And you know, if you're going to, I know Peggy does this too, but before I see a patient, I want them on what used to be called Periostat, but it's doxycycline, low-dose doxycycline. I want them on that for 2 weeks to reduce the inflammation. And if people out there don't know what doxycycline is on the low dose, they really need to go research it because it's not an antibiotic, so it's not in there killing it. The other thing that I do that's a little bit different is I will place Emdogain, which is a bone rebuilder.
Right.
So there's lots of different ways and different things to do to it as a hygienist to, you know, go out there, learn it, understand it, research it, and see how it fits in your practice.
Mm-hmm.
I think we're just very, very forefront of this technology. As Francis alluded or mentioned, Emdogain and Periostat, you know, there's been a lot of research done on them, but I think new research needs to be done on Periostat because I don't like to work without it. And if you ask the traditional periodontist or the general dentist, they're not that sold on it because it's all been done under the parameters of blind scaling and root planing. Same goes with Emdogain. It's kind of one of those things that's hard to prove that it was beneficial, and is it worth the cost? Well, if you ask the patient, yeah, it really is. But I believe that Emdogain needs to be done, the research needs to be done using the Perioscope as well as did I say Emdogain or Periostat? Anyway, I think both of them need to be done in conjunction with Perioscopy because I think the results from a Perioscopy provider, the results with the Emdogain and the results with the Periostat are just so completely different than the way it's been researched in the past.
Mm-hmm.
With the blind scaling and root planing.
So with Periostat, Peggy, are you talking about just before treatment, or are you saying like over months, right?
Especially, there are some people that I've have had them on Periostat for years because, quite frankly, I'm afraid to take them off. Those people with refractory perio,
And
what it
smokers.
enzymes and smokers, it's an enzyme suppressor. It teaches your body how, it changes the way your body responds to the bacteria. So it's not that it's an antibiotic. I don't even want their body to get a hint that this is an antibiotic. I only want it to be a collagenase inhibitor. So keeping these people on Periostat, putting them on prior to the perioscopy procedure, and then keeping them on for a significant period of time. Now, if they're a patient that it was all about the calculus or the bioburden, the biofilm, bioburden on the root surfaces and in that pocket, I don't mind taking them off on in a shorter time frame. But for those people that it's refractory perio, I want them on. I don't know when I'm going to have them come off, and if it's okay with them, we just keep them on for years. Once again, there would be the rationale for a different research modality for Periostat.
Back to the marketing stuff. Can you guys kind of share some of the negative feedback you've received from dentists that you approached for this service? Like what do they say? Is it just so new to them or different that they just don't want to even take the chance? Or what are some of the things you hear from them?
Yes, the fact that perioscopy is not. One of the first things they do is they pick up the phone and they call their referring periodontist about the perioscope. And as we said before, if the periodontist is not on board with perioscopy, they negate the benefits or the effectiveness of it because they just don't know enough. They don't know enough about perioscopy. So, which is why I offer them the opportunity to come in and do it at cost for a patient for them. The other thing for the hygienist is if they're getting paid an increased wage for perioscopy services, they really don't want me coming in and taking away their wages.
Right.
So those have been two of the biggest factors for me, and sometimes they just really don't care about. Sometimes they just don't. They don't want to. It's a lot more talk, and they don't want to do that.
Yeah.
If I could get in there and do it, I'd be happy with that. But those have been my limiting factors: is getting something new into the practice.
How about you, Francis? Same kind of thing? Or?
Yeah, I mean, it's basically, do they understand why this is valuable, why it's important? But the other thing is the cost. The cost of the supplies. Both Peggy and I are hoping that the cost of the supplies go down because it is an expensive tool. And not only just to buy the machine, but to buy the sheaths and the explorers and the fibers. It is not inexpensive at all. And so a dentist sees that, and of course, click, 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 that's money going out the door. How much are you going to bring in for me to offset that? So that's why I do the same thing as Peggy. This is just a flat rate, covers my costs, covers my supplies, but it's lack of education. To me, that's the biggest thing, lack of education.
Let me tell you just some of the things that we can do in addition to root debridement. To me, one of the best things about it was that as I'm down in that pocket and I see some recurrent decay, I see a fractured root, I see cement on the implant, I see a perforated root canal. Those are all easy. All I have to do is turn the patient's head take a look at this. Let me show you what I'm seeing on the screen. That was an easy sell. Okay, you need a new crown, you need a new, let's get this implant taken care of. I do a fair amount of periimplantitis, treatment therapy, because there's, you know, what's causing this, the pus, for, you know, what's causing the periimplantitis. So I do a lot of exploration in those type of pockets. So it's not just about periodontal therapy, it's about an exploratory mission, if you want to call it that, into that subgingival environment that's very, very beneficial. But you have to get the dentist on board. Probably the most expensive procedure I do is a one site therapy, because once I open that sheath, that's $100 right there. Right. Just to open that bag for that sheath is $100. I have to tack on the use of my fiber, because a fiber is only as good, you know, is only good for anywhere from, I have had a fiber used three times, and there's no amount that can cover that cost, versus, you know, I can get a fiber to last 70 uses. There is a huge variation in the cost of that fiber in that aspect. I like to, because I don't do a, because I debride and I explore at the same time, I wear out my explorers faster, the holders, faster than I would if I didn't keep them in the pocket at the same time, because I nicking them as I'm working. So there's a huge variation in the cost per procedure. So a single, if I'm looking to see, is there a huge pocket here because the root is fractured because of the root canal? That's an expensive procedure for the patient. Versus if it's 4 quadrants of scaling and root planing, that's really not such an expensive procedure.
Yeah. What's the average cost per use, would you say, Peggy, roughly? You know, just.
You know, we were talking, all those questions that you gave me, that's the one I really can't give you.
Yeah.
Okay, because there's so many variables. We both, Francis and I, have old machines, so my machine's paid off. But I still have to factor that in, because if I have to get it maintained, or if I have to get it fixed, that's a big cost. So I figure that $50 of my $300 fee per use is for my machine. I figure another $100 is for my sheath. So just immediately, $150 is just the disposables. You're going to have to figure in another $25 for my Explorers, because the Explorers, there's 4 in a set. They're $180 per, and I get a new set of Explorers almost every fiber. So now let's talk about the fact that I purchased my own ultrasonic unit, and I have to have tips. So I have to have a left, a right, and a straight, which we call a 3 brothers. I like to have the left, the right, and the straight with the bifurcation, and I like to have a diamond. So all of those things have to be replaced. So that's where the expense gets
goes out,
ambiguous. Okay, I don't know if I can give you a per. I don't know that I can figure that out for you.
I gotcha. So as far as the patients go, how's the feedback been from them as far as, you know, offering this service at a higher price than blind SRP?
It makes sense to them. They immediately want it done. I have yet to have a patient say, "Why would I do that?" If they understand it and the outcome is so much better, I mean, why would you not? Why would you not want to be able to see where you're going? Why would you not want the operator who's got something sharp in their hand to not see where they're going? So, and especially when you tell them that It's their other option is to go to a specialist and have gum surgery and the healing from that and all of that. And this is a non-invasive, you know, a couple Tylenol, you're good to go. You don't miss work. Much more cost-effective for a patient. So the patients get it right away.
And the patients, I have yet to have a patient say, "I wish I hadn't done it."
Yeah.
They have to say, "Why didn't we do this? This is a no-brainer. Why didn't we do it?"
Mm-hmm. Do you guys present it like, you know, I can do it blindly, but do you guys kind of approach it that way, or, you know, I mean, I can do it blindly, but, you know.
I have to have pretty much the other hygienist sell it for me.
Mm-hmm.
Okay, I have to count on other people to sell it for me, which I've, you know, the practices that I'm in, they're all on board. They get it. They don't have any problem. But because I come in and I do it for them, I don't really get to do it on my own patients at this point. So I have to have another hygienist sell it for me, and they're good at it at this point.
So in your case, Peggy, they're already sold because they're already scheduled with you, right? Basically.
Correct.
Yeah.
Correct. Yeah.
That's pretty much the same with me also.
Mm-hmm.
The other hygienist or office person is who sells it. So you've got to train them in the understanding of it also, so that they know. But yeah, so by the time I see them, they're already scheduled with me. They already know what to expect, and I just, you know, reinforce what has already been told.
Mm-hmm. So as far as price, I know the new system is about 20,000, which is something like that, right? Right.
Mm-hmm. Yeah.
And there are no more old systems available, or parts for the old systems, or do you guys know much about that? I know.
Well, something really kind of good came out of this. So as Francis said before, there's a new company called Periodontists, and they're what had happened, they were a godsend for me, because I pretty much spent my savings to get my 2 machines and all the supplies, all the equipment necessary to get my business up and running. So a year ago, Dr. Kwan sent us an email and said, the new machine is here, so I'm no longer going to provide the fibers for you, the cameras for you, which meant that we were no longer going to, so I was out of luck. I was either going to have to buy a new machine, or I was going to have to stockpile. And at $2,500 a fiber, I don't really have that kind of a liquidity to be able to stockpile $2,500 fibers. And he didn't have that many anyway. So here along comes Periodontists, and they say, "Hey, we're here, we're going to provide new fibers for you, and we're going to fix your machines, and your fibers are going to be at a lower cost." So lo and behold, Dr. Kwan then said, "Oh, by the way, we'll still fix your machines for you, and we're going to continue to provide fibers."
Mm-hmm.
So it was a boon for me, because it gave life to my business, because I really didn't know that still at this point don't want to have to buy a new machine. I want Danville to make the necessary upgrades to a machine, because they're coming. Why would I want to spend $20,000 on a new machine when upgrades are coming? So I'm trying to hang on to my older DV2s,
yep,
which is the old machine, until Danville has put the time and the money into making the new machines more user-friendly, because I think that the new machine that Dr. Kwan, I'm so grateful that Dr. Kwan did what he did, because he gave us life. But when it came right down to it, he basically made a new machine to get a new company interested in buying it from him. he did, in my estimation, the bare minimum to get somebody interested in the new machine. So I don't want to buy a new machine until the modifications have been made.
So Danville is upgrading the new machine?
Correct.
I see.
And there are still some old machines out there. You know, the best thing to do is called perioscopy, and how do you say it? Perioscopy, endoscopy? I don't know.
Periodontics and
Periodontics. Call them because they have taken over a list. Because Dr. Kwan had a list of people that wanted to sell theirs, and that's how I bought mine. And when he quit doing that, and I would think Danville has a similar list. So if you do want one, I do know they're out there. And I do know some people that have some that never used them. You know, when this first came out, it was sold predominantly to periodontists. Well, a periodontist doesn't want to really take the time to do this. And hygienists come and go through a practice, so they never really kept them up. So there are some old ones out there that, you know, if you really want one, you can find one, I'm pretty sure. Yeah. Or you can buy the new one if you have $20,000 laying around.
I don't have that.
Me either.
Yeah.
I believe that that's the best way for a hygienist. If there's any way that she could get financing, like maybe through the Small Business Administration. We're trying to get small business. I personally think that that is the best way to do it. I have done it because I get the money from what for my hard work. I don't want to just work as at an hourly rate, and the dentist gets all the money for the procedure that I just did.
Yeah, to me it just makes sense the way it is now, because it's not a common thing, obviously, to be out there, the perioscope, and it takes training to learn, a lot of training and money, of course. So it seems like a very good opportunity for a hygienist to have their own business and, you know, make decent money, and as opposed to waiting for a dentist to buy their own. And I mean, you know, it's not going to happen. So
can we talk about the elephant in the room, and that would be the laser? Okay. Yeah. Because a lot of people and a lot of periodontists want to use a laser and a lot of general dentists are very happy to buy a laser. Now, I talked to the periodontist into getting the laser, but once we used the perioscope, the laser really was. I'm not going to say that it's not a good addition to adjunct to the perioscope, but I believe that but it cannot be used as a bacterial debridement in periodontal therapy, because the studies just don't show that that's what the laser does. The laser does not do bacterial decontamination. Mm-hmm. My personal opinion is that the laser helps with wound healing, that photobiostimulation, that it helps with the wound healing. I don't think it's got anything to do with the decontamination of the pocket. Right. I think we're lucky enough to get enough of the biofilm debrided from that pocket, and then the laser was assisted. But if a dentist is willing to buy a laser and the patient has to pay out of pocket for the laser treatment, why wouldn't they be willing to buy the perioscope at the same price
point?
You know, that perplexes me. So
it just seems like it's a challenge just to get a lot of dentists just to replace ultrasonic tips. You know what I'm saying?
Right. You're exactly right.
Yeah.
I'm not going to lie. Dentistry has changed a lot over the 40 years that I've been in dentistry, and you have to have a very special dentist that's willing to buy all of those things. So
I'm a big advocate, Peggy, of buying my own stuff. I own 3 ultrasonic scalers. I buy all my tips, my everything. I buy everything.
Yeah.
So do I. So do I. Yeah.
I don't bother waiting, because it's not worth it at all.
I agree. I'm on my third pair of loops. I have the light. I have my chairs.
Yeah.
I have my I have 2 ultrasonics. And at the request of Dr. Kwan, I purchased one, a manually tuned one that I basically use as a door stopper. It works not that effectively. If I had my brothers, if I had my wherewithal, I would purchase the new Q3D EMS Piezo.
Like air polisher thing, right?
Because I think air polishing and the glycine with the Perio Handy is like the newest, greatest, latest thing out there. So in conjunction with the endoscope.
Yeah.
I have to say one other thing that I use that I absolutely love is what you created, Mark.
Thank you.
And I can't remember what you call it.
The Kona adapter.
The Kona adapter. I love that thing because you are now not only putting a little water in there, you're using an ultrasonic, you're using a piezo, perioscope that has water. So, and you don't have an assistant. And that thing has been a lifesaver for me. So,
yeah.
Kudos to you.
Amen.
Thank you. The only negative thing I would say about any of those systems, so dry shield, isolate, whatever, is sometimes you lose room in the back. So like on certain patients, like on the distal of the last molars or something like that. But other than that, yeah, it definitely helps a lot.
Definitely.
So what would you guys say to a hygienist like myself or anybody else that's looking to do this as a business? What are the general advice as far as approaching, where to start, what what to buy? You already mentioned, Peggy, about it's probably a better idea to either wait for Danville to upgrade or to maybe find an old system to start with.
Exactly.
Yeah.
I would find an old system. And there are a lot of perioscopy providers out there who would love to mentor you. Okay, I would love to mentor you, and Francis would love to mentor you. One downfall to my business is the fact that I get into an office, I do all the perioscopy, and then the hygienists want to do it. So then I end up training the hygienist, and I lose that part of my business. But I'm cool with it. Training. I want all hygienists to be good at what they do. Francis, would you agree? I think the perioscope made me a better hygienist.
Oh, definitely.
Mark, where you think the tip of your ultrasonic or your power tip is and where it really is are 2 different places.
Oh, I can imagine.
When you see how long it takes to get the biofilm out of that pocket, it is an eye-opener. It makes you a better hygienist. What I would tell you to do is find somebody and go to and work with them. I would love for you to come to me and let's work together. Let me show you let me show you what you can do. You don't know what you don't know. It's like teaching somebody why they should use loops in a light.
Yeah.
See, I don't know what magnification your loops are, Mark. Mine are now 4.5.
That's what I use. Yeah.
Because you don't know what you don't know. So find somebody to mentor with and start there.
Yeah, I was looking at Dr. Kwan's website. They have a list of providers, and the only one in New England is that on that list is in New Hampshire. So I was actually thinking of contacting them and kind of combine it as a visit for myself to kind of check out the equipment and see what they're doing with it and so on. But also to create like a podcast too, all at the same time if they want to talk about it,
Absolutely. Can I tell you, it's really, really inexpensive. Part of the reason why it's awesome in Las Vegas is that it's just easy to get here. It's not real expensive to fly to Las Vegas. You can, So if I don't know how far it is for you, but come. We would love to have you, and Dr. Kwan is the same way. Francis is the same way. We would love to have you come and just watch what we do. It's so exciting.
Yeah, I'm supposed to be going to the Dental Town meeting. I think it's in April, and it's in
Oh,
Las Vegas. It's in Las Vegas, so if you guys want to kind of coordinate something
Call
at the same
me
time.
and let's do it.
Yeah.
sounds
Yeah.
good. Sounds good. But I agree with Peggy. Find somebody up there that does it. You know, several of the schools, I'm actually amazed how many of the schools have one, but not necessarily know how to use them, but somebody may know how to use it. But go watch for the first time, because the first time you see it on a screen, you can't tell what's going on, and you just kind of go, whoa,
Right.
and then all of a sudden the light goes off and you get excited. But go watch somebody first, and then go from there. And if we hear, where are you at, Mark?
Near Boston.
Boston. Oh, I should have known from your accent.
Yeah.
If I hear of somebody up there, I will definitely,
Yeah.
let you know and say, just go by and watch. I also know that at some of the dental meetings, Danville and Suzanne are now taking theirs with them, and so that's kind of nice for people to see. But you're right. I agree with Peggy 100%. Find somebody that does it and mentor them. And you can call me, you can call Peggy, you can call so many of them out there and say, help. And
We love to show you what it does. It is the most exciting technology out there, and I just don't understand why every hygienist wouldn't want to do this. It's cost effective for a patient.
It seems like every scope user basically says once you start using it, you can't go back to blind. Like,
That's right.
yeah,
Why would you want to?
exactly.
Would you want to go back to using just like
No.
glasses? Why would you want?
or hand instruments.
I've been using 4.5 loops and a headlight for a couple of years, and
Yep.
I mean, if my loops, I have two sets of loops. I mean, I have backup loops and light. If I don't have my loops, then it's like I can't do any real work. I mean, I can't.
One day my light went out, and it was back when I worked at the Perio office, and I whined so much the whole morning that my doc said, "Okay, come on." And at lunchtime, he helped me put the light, fix the light, the new replacement light. I can't work without it now. Well, that's how I feel about the Periscope. I can't work without it now. Why would I want to?
Exactly. Yeah. I had this thought too, guys. Like, as far as like getting into the business and providing the service, but also like, because you mentioned, Peggy, how you go into an office and you treat a patient. Now the hygienist wants to learn, and you train that hygienist, and they kind of do it. So what do you guys think of almost like a secondary service? Is you basically offer the service, but you also offer training at the same time.
Correct.
You know what I'm saying? Almost like, make money doing that too.
Correct.
Yeah.
Yeah. I have to tell you, there's one particular office in town. The hygienist happens to be one of the Nevada State Board dental examiners, and they are doing. She's doing probably 10 a week. Her doctor went on board. He actually did a YouTube, kind of a rant about why every office isn't using a perioscope. But he was a hard sell at first. He was really a hard sell. In fact, she called me one day and said, "Could you talk to him about why I spent my money?" So I went to bat and got him more money per hour for being a scope provider, because it's hard work, but it's so much rewarding.
Yeah. Because my thought for me is, I thought about going to dental school, but I'm 43 now, and I don't know. I'm still relatively young, I guess. I know, but still. Because I have the business. I sell my product, and I work full time still, and so I make pretty good money. So it's financially, it wouldn't really help me that much, and it would cost a lot of money to go to dental school and time and all that.
Yep.
But my thought was, I would like to be more independent, and like, as you guys know, as hygienists, it's tough to be independent. So this, to me, it seems like a very nice opportunity to have a business and be pretty much independent. Like, if I go in and be seen almost like a specialist, like doing a certain very specialized service, and then I'm done.
Right.
Yeah, I think that's probably I think that's one of the things you have to learn and know as a hygienist, what your state will allow you to do. So what kind of wording do you use when you do this? You know, Colorado, that's a no-brainer. That's easy.
That's easy, yeah.
That's not hard. Peggy had a different road that she had to go through to get to make sure she was doing it correctly through her state, because you don't want to lose your license over it either. So just make sure you know exactly what the wording is, and definitely, I think hygienists in general have so much to offer and should be in more areas than what we're in. I've often thought that they should be in a hospital setting, working for orthopedic surgeons, working, you know, there's just so many other avenues, and so it just takes you as that hygienist to take that step out there and go for it. So that's what I would tell. If you've got a dream, if you've got a thought, go try it. You got nothing to lose.
Yeah.
I would like to work for in conjunction with a nephrologist, because there wasn't one kidney transplant patient that didn't have to get clearance from the perio office that they were infection-free before they got their kidney transplant.
Right. Interesting. Very good. I think I've hit all the questions that I had. Do you guys have anything you want to mention that we haven't talked about?
Oh, Mark, I just so want you to take that leap of faith.
Yeah. Oh, I do.
Because you will never regret it. You will never regret. It makes you passionate about what you're doing again. You're off because most hygienists are in this for the same reason. I have no interest in becoming a dentist. I don't want to do fillings and crowns. I want to make their oral health perfect. I want to do my job perfectly. That's why I am a hygienist, right? Aren't we all a little bit type A?
Yeah.
And perfectionist. Perioscope allows me to tap into that aspect, and I just want to encourage you to take that leap of faith and come visit me. Go visit Francis. Go visit Judy Carroll, Dr. Kwan, any of the number of people that are out there, Lynn Groff. There's a ton of us. Take that leap of faith and just get started.
Yeah, I think my first step is going to be to contact the office in New Hampshire and see what I can do there. See if I can go up there and do a podcast. Take some photos and video and share that on my blog and to see how, because I want to see it in person too. I want to see.
Oh yeah, yeah.
If they're not passionate about it, though, they're not going to be good. If they're not passionate about it, find another office.
Yeah.
If they're just using it once a month, that's kind of a red flag. They don't see the value in it.
Yeah.
Find somebody that uses it on a regular basis, and go from there.
Yeah.
The other thing, just because they're on Dr. Kwan's website doesn't necessarily mean that they actually use it.
Yeah.
It means that they bought one. But I know I have just Google searched perioscopy offices in certain states just to see what's out there, and you'll see some out there that aren't on his list. Yeah. So I know there's a couple in New York. So I know you'll find one. You'll probably find one right down the street.
Yeah. I mean, I'm hoping to be doing this next year. By next year, like.
Amen. Good.
That's my goal. Because I work 4 days a week. I have the business myself, sell my product and all that, and with the blog, I want to monetize the blog too at some point, some way. But I'm off Mondays, so if I can maybe start off on doing this on Monday, and then kind of go from there, and because eventually I want to back off on my regular clinical hygiene stuff, because I really want to do something special like this,
Absolutely.
Yeah.
I'm a single. It's just me. I'm a single mom. I put my 2 kids through college and law school with this. It's definitely worthwhile, but I don't have that luxury of being able to back off. But my goal in the next 5 years is not to have to do additional therapy, hygiene anymore, and to just do perioscopy. So.
Yeah, I think that's going to take a lot of late work, like you said, Peggy, and a lot of just getting out there and trying to get people to understand what this is, you know.
Well, I'll let you know what happens with the Teamsters meeting that I have.
Yeah.
Because if I could get into the Teamsters, that would just be a big break, because it takes one break to set precedents, and if I can get one insurance company to pay for the procedure,
Yeah.
then I could get others. So that would be my goal, is to set a precedent on that one, to get into that, to tap into that market.
Yeah, that makes sense from the insurance perspective too. Yeah, like, because if the patient can avoid surgery, it's a money saver for them.
No brainer.
Yeah. So.
It's no time off work, or minimal day of the procedure, but there's no real. They have less discomfort after this procedure than they do with blind scaling and root planing.
All right, guys, it's been over an hour, so I don't want to hold you too long.
Well, as you can see, we like talking about this. Or at least
that's good, because
it's my passion.
A lot of hygienists out there, and dentists and everybody else, they're not really into their career as much, and it's nice to be around people that are into it, and passionate about it. So.
Well, keep us posted on what you end up doing. We're definitely in your corner.
Well, I'm going to stop the broadcast for a second. I'll just stay on for a sec, all right?
Okay.
Sure.
All right.